Welcome to pharmafanatic, the ultimate pharma guide. This video includes cholinergic transmission, synthesis, storage, and release of acetylcholine, cholinesterase, cholinereceptors, cholinergic drugs, anticholinesterase, and anticholinesterase poisoning. In this session, we are going to learn about cholinergic transmission and cholinergic drugs. Before we dive into cholinergic transmission, do you heard about a chemical called acetylcholine? Acetylcholine is a major neurohumoral transmitter at autonomic somatic as well as central sites. It is a basic chemical involved in cholinergic transmission. So comes the next question: how this acetylcholine is synthesized inside our body. Acetylcholine is synthesized locally in cholinergic nerve endings. For that, acetate and coenzyme A undergoes acetate activating reaction to form acetylcoenzyme choline, which is actively taken up by sodium choline cotransporter react with this acetylcoenzyme A in the presence of choline acetyltransferase to form acetylcholine, and coenzyme A choline uptake can be inhibited by hemacholinium, thereby inhibiting the entire process and depletes acetylcholine synthesis in the body. This formed acetylcholine is stored in synaptic vesicles, which is entered by vesicle-associated transporter VAT, and this process can be inhibited by a chemical vesimicol. Acetylcholine is released from nerve terminal by a process called exocytosis. Hope you understand the synthesis, storage, and release of acetylcholine. Now who's going to control or inhibit the level of acetylcholine in the body? For that purpose, body itself have an enzyme called cholinesterase, which causes the hydrolysis of acetylcholine into choline and acetate. So we studied about acetylcholine. Where did these chemicals act? Probably it may be on receptors, right? Yes, for acetylcholine there is a specific receptors which is known as cholinereceptors. Depending on the location, function, nature, and type of receptors, cholinereceptors are classified into muscarinic and nicotinic receptors. Muscarinic receptors are again divided into M1, M2, and M3 receptors, and nicotinic receptors into N1 and N2 receptors. So let's dive into M1 receptors. M1 receptors are located in autonomic ganglia, gastric glands, enteric neurons, and CNS. When acetylcholine interact with M1 receptors in autonomic ganglia, it causes depolarization of the same. It produces histamine release and increase acid secretion in gastric glands, increases intestinal secretion in enteric neurons, and help in learning, memory, and motor activity by acting on CNS. It is a GQ protein-coupled receptors and act by IP3-DAG or PLA2 pathways. IP3-DAG pathway increases the level of cytosolic calcium ions, and PLA2 increases the prostaglandin synthesis. It is stimulated by oxytryptamine and inhibited by pyranxipine. Second muscarinic receptor is M2 receptor, which is present in SA node, a V node, atrium, ventricle, cholinergic nerve endings, CNS, and visceral smooth muscles. In SN node, it produces hyperpolarization and decreases the rate of impulse generation, decreases velocity conduction in AV node, shortening of action potential duration, and decreased contractility in atrium, decreased contractility in ventricle. It also reduces acetylcholine release from cholinergic nerve endings, tremor and analgesia in CNS, and contraction of visceral smooth muscles. It is a GIGO protein-coupled receptors which causes potassium channel opening and reduces cyclic adenosine monophosphate. It is stimulated by methacholine and inhibited by methoxytramine. The final muscarinic receptor is M3 receptors. It causes contraction of visceral and bronchial smooth muscles, constriction of pupil, contraction of ciliary muscles, secretion of exocrine glands, and release of nitric oxides, which results in vasodilation. It is a GQ protein-coupled receptor act on IP3-DAG and PLA2 pathways. It is stimulated by bethanchol and inhibited by solifnasin and darifnasin. Next, we can move to second class of receptor, that is nicotinic receptors. First is NM receptors, which causes contraction of skeletal muscles by depolarization of muscle end plate in neuromuscular junction. This is a pentamer receptor with alpha-2, beta, gamma, and delta subunits and has 4 TM segments. It causes opening of sodium and potassium channels. Nicotine is its agonistic drug and tubercularine is its antagonistic drug. The second group of nicotinic receptor is NN receptors. It causes depolarization of autonomic ganglia, catecholamine release from adrenal medulla, and site-specific excitation and inhibition of CNS. It's also a pentamer with alpha and beta subunits, and each subunit has 4 TM segments. It causes sodium, potassium, and calcium channels to open, agonisted by nicotine and antagonisted by hexamethonium. So we are done with basics of cholinergic transmission. Let's dive deep into cholinergic drugs. They are also known as cholinomimetic and parasympathomimetic. These drugs directly interact with cholinergic receptors and produces similar actions as that of acetylcholine. Cholinergic drugs or cholinergic agonists are further classified into choline esters and alkaloids. Choline esters include drugs such as acetylcholine, methacholine, carbachol, and bathynchol. Alkaloids include muscarine, pilocarpine, and ericoline. Acetylcholine produces muscarinic, nicotinic, and CNS action. Muscarinic actions are produced in heart, blood vessels, smooth muscles, glands, and eye. In heart, it produces hyperpolarization of cyanode. Further, it decreases rate of diastolic depolarization and impulse generation, which causes bradycardia, which means slow heart rate, and lead to cardiac arrest. In case of Avnode and Purkinje's fibers, refractory period increased and conduction slowed. In heart, they produce action by interacting with M2 receptors and lead to atrial fibrillation and atrial flutter. All blood vessels receiving cholinergic innervation causes vasodilation. By acting in muscarinic M3 receptors lead to fall in blood pressure and flushing in blush areas. These effects are produced due to endothelial-depending release factors such as nitric oxide, by PLC-IP3-DAG pathway through calcium-comedulin mechanism. Stimulation of cholinergic nerves by releasing nitric oxide lead to erection of penis. Smooth muscles get contracted by action of acetylcholine. It produces its effect by interacting with M3 receptors. It increases tone and peristalsis of gastrointestinal tract, which causes sphincter to relax and lead to abdominal cramps and evacuation of bowel. Similarly, peristalsis in ureter increased, causing voiding of bladder. Bronchial muscles contract, which lead to bronchospasm, causing bronchial asthma. In glands, by interacting with M2 receptors, secretion of all parasympathetically innervated glands is increased. Sweating, salivation, lacrimation, tracheobronchial, and gastric secretion get increased, but do not have a significant effect on pancreatic and intestinal glands, and not effect on milk and bile. In eyes, constriction of iris lead to miosis. In addition, it produces effect like ciliary muscle contraction and reduction in intraocular tension. Next, let's discuss about how acetylcholine acts on nicotinic receptors. It produces its effect on autonomic ganglia and skeletal muscles. In autonomic ganglia, high doses of acetylcholine on combination with atropine may lead to tachycardia, rise in BP, and release of catecholamine. In skeletal muscles, it have iontophoretic application on muscle end plates, causes contraction of fiber. High doses of intra-arterial injection of acetylcholine lead to twitching and fasciculation. On IV injection, it produces no effect. On IV injection, acetylcholine does not cross as BBB. Direct injection, it produces arousal response followed by depression. It produces complex behavioral and neurological effects. When anticholinesterase coupled with acetylcholine lead to synergistic action, and with atropine it produces antagonistic action. Example of cholinomimetic alkaloids are pilocarpine. Pilocarpine increases secretions such as sweating and salivation. Small dose of pilocarpine produces fall in BP, and high doses lead to tachycardia and cardiovascular system. 0.5 to 4% drug is used in eye for open-angle glaucoma. It have adverse drug reactions such as stinging sensation and painful spasm. Another category of cholinergic drug is anticholinesterase. Anticholinesterase is the group of chemical which inhibit the enzyme cholinesterase. These drugs prevent the hydrolysis of acetylcholine. Anticholinesterase category of drugs are further divided into reversible and irreversible classes. Reversible drugs include carbamates and non-carbamates. Carbamates are physostigmine, neostigmine, pyridostigmine, and rivastigmine. Non-carbamates include edrophonium, tacrine, donepezil, and galantamine. Irreversible class is subdivided into carbamates and organophosphates. Carbamates are carbaryl and propoxyl. Organophosphates include diflose, ecothiophyte, malathion, and diazinon. Now let's discuss about mechanism of action of anticholinesterase. Cholinesterase enzyme contain two sites, anionic and esteratic site. Drugs such as carbamate and phosphate carbamylate and phosphorylate the esteratic site of the enzyme. Hydrolysis of acetylcholine involves electrostatic attraction of positively charged N+ ions of acetylcholine to anionic site, and nucleophilic attack at serine acetylation of histidine. Acetylated enzyme react with water to form acetic acid and choline. Acetylated enzyme react with esteratic site very rapidly. Carbamylated enzyme react with esteratic site slowly, and extremely slowly in case of phosphorylated enzyme. Now let's dive into pharmacological actions. lipid-soluble drugs such as physostigmine and organophosphates produces muscarinic and CNS effect. And lipid-insoluble drug such as neostigmine produces its effect on skeletal muscle and stimulate ganglia. Anticholinesterase stimulate ganglia by acting on nicotinic receptors. High doses produces persistent depolarization of ganglionic nicotinic receptors, which causes blockade of neuronal transmission. In cardiovascular system, bradycardia and hypotension are produced by acting on muscarinic receptors. It increases heart rate and blood pressure by ganglionic stimulation, and ganglionic blockade occurs at high doses. Retrograde activation of prejunctional fiber causes repetitive firing in skeletal muscles, which results in twitching and fasciculations. Weakness and paralysis of skeletal muscle is caused by depolarization of end plates. Lipophilic anticholinesterase penetrate into the brain and causes improvement of cognitive function in Alzheimer's. High doses of anticholinesterases in CNS lead to excitement, mental confusion, disorientation, tremor, convulsion, and coma. Other effects of anticholinesterase include enhanced gastrointestinal motility, enhanced secretion, bronchoconstriction, voiding of bladder, meiosis, contraction of ciliary muscles, and lowering of intraocular tension. So now we get to know about how these drugs act in our body. Next, let's dive into pharmacokinetics. That is how body react to drug. Drugs such as physostigmine are rapidly absorbed, easily crosses BBB, and mainly used in eye. Drugs such as neostigmine are poorly absorbed orally. Oral dose of these drugs are 20 to 30% higher than parenteral dose, does not crosses BBB, and partially hydrolyzed and excreted in urine. Organophosphates are absorbed from all sites, hydrolyzed and oxidized in body, as well as excreted unchanged from the body. Anticholinesterase is contraindicated in patient with sick sinus, AV conduction, and hypotensive states. It is carefully used in patient with peptic ulcer, asthma, hypertension, COPD, and seizure patients. It is used as miotic, myasthenia gravis, post-operative paralytic ileus, or urinary retention, post-operative decurization, cobra bite, belladonna poisoning, other drug overages, and Alzheimer's disease. Treatment regimen for myasthenia gravis. Initially 15 mg neostigmine are administered orally in 6-hour interval. If it is not cured, thymectomy is done, followed by corticosteroids such as prednisolone 30 to 60 mg per day, immunosuppressants such as azathioprine and cyclosporine, then removal of antibodies by plasmapheresis, and, finally, myasthenic crisis occurred. If the dose of anticholinesterase is not adjusted according to time, it can lead to overdose. It can be identified by injecting 2 mg edrophonium IV. It is known as edrophonium test. If improvement occurs, then it's due to myasthenic crisis. And if there is no improvement or worsening, it's due to cholinergic crisis. Other diagnostic tests are ameliorative test, provocative test, or muscle biopsy specimen. So now let's discuss about final topic in this session. That is, anticholinesterase poisoning. Anticholinesterases are easily available and extensively used as agricultural and household insecticides. Accidental suicidal and homicidal poisoning are most common. Common clinical manifestation of anticholinesterase poisoning are irritation of eye, lacrimation, salivation, sweating, copious tracheobronchial secretion, meiosis, blurring of vision, bronchospasm, breathlessness, colic, involuntary defecation, and urination, fall in BP, bradycardia, tachycardia, cardiac arrhythmias, vascular collapse, muscular fasciculations, weakness and respiratory paralysis, irritability, disorientation, unsteadiness, tremor, ataxia, convulsions, coma, and death. Death is generally due to respiratory failure. Next, how can we treat anticholinesterase poisoning? For that, we can treat further exposure to the poison fresh air, wash the skin and mucous membrane with soap and water, gastric lavage according to need. Maintain patent airway, positive pressure respiration if it is failing. Supportive measures maintain BP, hydration, control of convulsion with judicious use of diazepam. Specific antidotes, such as atropine 2 mg Roman 4 repeated every 10 min. Maintenance dose for 1-2 weeks. Cholinesterase reactivators are employed, such as oximes, pralidoxime. Here comes the end of this video. Thank Haiwu for watching. If you find video is engaging, then subscribe to Pharmafanatic for more pharma-related contents.